It's an absolute pleasure to be here. The topic for today is Epidemiology, Etiology and Histology of RCC. I'll try to be in brief, and that would be for the benefit of trainees. So the data in 2018 from European 40 countries does mention about the age standardized incidence rates for kidney cancers. It amounts to about 13.3 in both sexes, and in men it is about 18, and females it is about 9. Counterproductive mortality rates are approximately 4.7 per year in both the sexes together, and in men it is 7.1 and females it is 2.7. The bracket which I have highlighted here is for the Uro-Oncology, and obviously incidence wise, prostate stands first, bladder comes next, and then the kidney, and similar things happen in mortality rates as well. So as per the European standards, the most common age group is about 60 to 70 years. Nearly 60% are diagnosed at T1A stage, which is quite good. Male to female ratio is about 1.5. The US statistics are nearly 3.8% of all the tumors are attributed to kidney cancers. Median age is 64. In last 1 decade, approximately spanning from 2006 to 2015, the incidence is slowly increasing by 0.6% per year. Mortality is reducing by around 0.7% in a year. And most encouraging fact is that in last couple of decades, the 5-year survival both for localized and advanced disease is improved by around 4 percentage points. So Globocon data around at the moment in 2018, this is the statistics from 2018, of course, but the literature about the entire globe is as age standardized rates are about 6 for males and 3.1 for females. Similarly, the mortality rates are 4.5 and 1.8. If you can appreciate this, North America and then followed by majority European countries amount to the maximum incidence rates and similarly maximum mortality rates as well. Continuing the same Globocon data, Asia and Europe would attribute about 1/3 each of the total number of cases diagnosed for kidney cancer every year across the globe. And unfortunately, Asia would be having a large chunk of 45% mortality is happening because of the kidney cancer out of the entire statistics in the world. Coming to the Indians, the data for the benefit of Indian trainees, we are having a little early age of onset for this disease, nearly a decade earlier. So the median age stands about 56. Unfortunately, 30% of the people are younger than 50 years, which is a harsh reality. And only 10% are diagnosed in T1A stage. Majority are diagnosed at later juncture. Male to female ratio is much higher than the global statistics. It's 4:1. Giving the data about this data comes from obviously it was assembled in Tata Memorial Hospital. So it does mention that presentation. Obviously, it's a tertiary referral hospital, so there will be some bias in that. But 40% of the referrals are for metastatic setting. So what's happening in the future? If you totally in the globe, probably the incidence slowly is going to reduce until 2030. So we at least have prediction until next 1 decade. But there is a glitch in that based upon the socio-demographic income, the SDI, if you can appreciate in this figure, high and middle high SDI countries will have average annual percentage change in negative manner. That means the incidence is reducing. And similarly, exactly opposite to it, low, middle and low socioeconomic countries will have AAPC in positive manner. That means the incidence is still going to be increasing until 2030 slowly. Coming to the etiology, smoking obviously has been proven beyond doubt, and the dose response relationship has been already established. But to my surprise, actually, within 20 pack years, the incidence or the risk doesn't increase much. That doesn't mean that I'm allowing or asking people to have that much of liberty, but obviously 20 to 40 pack years, the odds ratio is about 1.3, and beyond 40, it's about 1.5. Obesity will be around 1.1. Hypertension obviously has a role varying between 1.4 to 3.2 as the odds ratio. There is a possible role of antihypertensive medicines, thiazides, which has been seen in few retrospective data, but obviously the data is not robust and we can't attribute exactly the etiological correlation. Occupational exposure doesn't stand much of a role, and there's no association of coffee, alcohol, or tea. The insights from the Placo trial, where these group were followed up for renal cell carcinoma as well, and the modifiable risk factors are exactly the same: obesity, hypertension, and smoking in pack years. Non-modifiable risk factor, of course, stand as an age. Interesting fact is that hypertension amounts to 67% increase in the risk, every 10 milligram increase in the systolic and diastolic blood pressure will have certain increase in the number of risk for kidney cancers, and diastolic blood pressure is more important than the systolic blood pressure. Last point in the etiology, end-stage renal disease is one of the most important factors for which contributes to these particular cancers because of the association of acquired renal kidney diseases as well as RCCs. Nearly 4% of ESRD patients will have tumors happening into their native kidneys, which is nearly 10 times the higher risk over the GenPop. These are generally younger males. It happens bilaterally, multicentric manner. Luckily, these are less aggressive tumors happening into low-grade varieties. More percentage would be papillary variants, less of nodal spread and less of metastasis, and hence the survival, cancer-specific survival, appears to be better with ESRD than non-ESRD. The actual benefit or actual reason for that can be either ESRD or the early detection. People have actually looked into it, and the data in this retrospective analysis in European Urology does mention that on multivariate analysis, ESRD doesn't stand as a risk factor, as a significant factor. Hence, they attribute early detection as the reason for better prognosis in these particular patients. So, coming to the histology, WHO, broadly speaking, the classification of renal tumors can be renal cell tumors of adult origin, or the metanephric tumors, then the nephroplastic tumors, which generally happen in children, mesenchymal tumors happening into children, and mesenchymal tumor occurring into adults. Neuroendocrine variety of tumors and metastatic tumors would attribute to smaller percentage, rare events, but they are theoretically described. So coming to the histology, I'm going to spend some more time on this particular slide for the benefit of trainees. Majority of, so we'll limit the discussion to pure RCCs now. So clear cell RCC, of course, stands as one of the most important etiological factor in this. Nearly 75% occurrence of clear cell variety. These are confined tumors, but there is no capsule per se into the tumor. The gross appearance would be golden yellow appearance of the tumor with some area of necrosis or hemorrhage. The histology would have lipid-rich ample cytoplasm, and hence the name clear cell. The second most common variety is, of course, the papillary tumor. These are basophilic cells with scarce cytoplasm. These tumors have pseudocapsule. The overall architecture has micropapillae, and the overall the support or the basal membranes of these particular tumors are very flimsy. They don't have a lot of good support around the tumor architecture, and hence these tumors have tendency to have, once the tumor overgrows, it forms hemorrhage, it forms exudate of some proteinaceous material leading to some osmosis, and the fluid starts accumulating inside. Hence, the tumor on gross section appears like a mint mease, or the histology-wise, these tumors will have some fluid inside. Imaging-wise, these tumors will have some fluid inside, and they would mimic Bosniak 2F or 3 cysts. The aggressive variety of papillary tumors is type 2 papillary tumors. It's more of eosinophilic over the background of papillary 1 tumors, which are basophilic. Coming to the third most common variety, chromophobe tumors. These are all solid tumors, and they do not have capsule of its own. These tumors do not have capsule of their own. Then histology-wise, they are more pale on the cross section, and histology-wise, they have a perinuclear halo, which is very characteristic of chromophobe tumors. The reason why they are solid, because of the reasons of being solid architecture and homogeneous, they are the differentials for oncocytomas, which are benign tumors, and it's difficult to differentiate both these tumors on the radiological diagnosis. The aggressive variants of other aggressive variants of the renal tumors, collecting duct tumors, these typically happen into collecting ducts, and they have a lot of dysplasia around. The medullary variety is going to happen in the distal nephrons, and there is marked pleomorphism and hyperchromatic nuclei into that. So the initial grading, or the Foreman grading, which was described in 1982, they used to include 3 categories for grading the aggressiveness of the tumor or the biology of the tumor, which would include nuclear size, nuclear shape, and the status of nucleoli. But with the recent ISUP modifications, they are focusing more into nucleoli for these particular grading. So grade 1 there will be either absent or very inconspicuous nuclei. Grade 2 would be having nucleoli which are seen on, which are eosinophilic, but which are well seen on 400 magnification, but not very well seen on 100 magnification. Grade 3 will be conspicuous on 100 magnification, and grade 4 will be either giant cells or some sarcoma type differentials. So if you can just appreciate in this figure, the nucleoli are becoming more conspicuous as we go from grade 1 to 4, and the giant cells come into picture in grade 4 as well. The learning point to be noted here is Foreman grading or a nuclear grading would be relevant for clear cell and papillary tumors. It can be applied for chromophobe variety because there is inherent nuclear atypia in the chromophobe variety, and hence we cannot use the nuclear grade for grading these chromophobe variety of tumors. So coming to some familial RCC or familial renal tumors, I have summarized some important familial syndromes out of which with some imaging findings so as to have a good clinical insight for the benefit of trainees. So VHL, it's chromosome 3 renal cell carcinoma happens about 24 to 45%. These majority allele clear cell variety of tumors. The screening initial starts at the age of 10 years with an ultrasound, and beyond 20 years we need to have a cross-sectional imaging at least 1 per 2 years, or depending upon that we have to increase the frequency. Some extrarenal manifestations would be retinal angiomas, cerebellar hemangioblastomas, which is well seen here. The type 2B VHL will have RCC, the adrenal mass or the pheochromocytomas, and they can also have extra-adrenal presentations. There will be some pancreatic cysts apart from basic renal cysts as well, and remaining pancreatic neuroendocrine tumors or endolymphatic sac tumors is a rare occurrence. The tuberous sclerosis is affiliated to chromosome 9 and 16. AMLs do happen in about 80% of the cases, and hence whenever it is diagnosed we need to keep them under good monitoring, because there is a slightly high propensity of these AMLs to bleed than the normal non-tuberous sclerosis AML. So the size criteria of around 4 cm for the overall tumor size and 5 mm for the aneurysm size is considered for decision making about active treatment versus just monitoring these sort of AMLs. So apart from these tumors, these syndromes will also have some renal cysts, like similar in VHL. Some extrarenal manifestations would be giant cell astrocytomas, retinal hematomas, skin manifestations like Ashley spots or Sjagren patches, and lymphangiomyomatosis in the lungs, which may lead to sometimes a pneumothorax formation and cardiac rhabdomyomas. So the third syndrome would be BHT, Birch-Hughes syndrome. That would be chromosome 17. Folliculin is the gene involved. These tumors will have oncocytomas and a combination of oncocytomas, a hybrid oncocytoma that will be a combination of oncocytomas and the chromophobe variety of tumors. So screening again starts at about 20 years. That's a cross-sectional imaging, and characteristic of these particular tumors as an extrarenal manifestation would be bibasal lung cyst, which lead to 24% chance of spontaneous pneumothorax. So whenever there is a pneumothorax presentation along with a renal mass, BHT, that should ring a bell, and BHT first followed by tuberous sclerosis. These should be the differential depending upon the criteria. So for diagnosing a BHT syndrome, we need to have one major or two minor criteria. One major would be at least 5 fibrofolliculomas or a proven germline mutation on genetic testing, or two minor criteria out of 3 would be multiple bibasilar cysts, which are characteristic of this, along with renal tumor and first degree relative with BHT syndrome. Hereditary papillary RCCs affiliated to chromosome 7, c-Met gene involvement. These are bilateral type 1 papillary RCCs. Of course, as we know, papillary RCCs are hypovascular. Just to summarize, papillary and chromophobe would be hypovascular, and the clear cell would be slightly hypervascular or hyperattenuating. So hypovascular bilateral tumors probably should hint us towards HPRCC. There are luckily no extrarenal manifestations in this particular syndrome. The aggressive variant of papillary is hereditary leiomyomatosis and RCC. Fumarate hydratate gene and chromosome 1 is included in that. These are slightly aggressive tumors, and they also manifest with cutaneous and uterine leiomyomatosis. Apart from these, there are certain other tumors which have familial association with RCCs, for example, WIMS, which may manifest in adulthood, HNPCC, PTN gene mutations, hyperparathyroidism jaw syndromes, and SDH mutation absence syndromes or involvement, which leads to some RCC formation. So I've typically highlighted these two varieties of tumors into red category because they are slightly aggressive. Hence, we cannot go by the size criteria, which is generally applied for all familial tumors, because these tumors are notorious to come back in the same kidney or into different kidney or contralateral kidney. So generally, the 3 cm criteria is generally applied for a majority of these tumors, but HLRCC and SDH mutation gene associated tumors preferably won't be eligible for these criteria of 3 centimeter for active interventions versus monitoring. So a little bit about the aggressive variety of tumors. Renal medullary carcinomas, these generally happen in younger males who may have sickle cell hemoglobinopathy in the background. They generally present with wide lymphadenopathy or metastasis. They are very aggressive, and the overall survival is limited to few weeks to few months, unfortunately. The Sarcoma variant is an aggressive variety. It generally is a high-grade transformation without being a distinct histological entity. And as we know, in spite of majority of the treatment options, the prognosis is very grave. Similarly, another aggressive variety called Carcinoma of collecting duct of Bellini, they also present with nearly 44% nodal involvement and 33%, nearly 1/3 would present with metastasis. They're very aggressive, and the median overall survival is about 30 months, just over 2 years. Last word about translocation associated RCC. These are RCCs arising because of RCCs happening because of some translocation related to MITF genes, family genes, that is microphthalmia transcription factor family genes. Two major genes are involved in this, are TFE3 and TFEB. The translocations can be 611 or X involving X chromosome, so X3 or X19. It is said that it is relatively underreported because of the lack of routine genetic testing on these specimens. They're more common in females. The mean age is about 43. They mind you that these genes are also implicated in melanoma, so there may be some association whenever the patient with previous history of some melanoma comes with a kidney mass. That should ring a bell, and we should think of these particular possibilities in mind, especially if it's a younger female. So these tumors would be identified on IHC for confirmation. TFE3, TFEB, cathepsins, HMB would be positive in these particular tumors, unlike standard clear cell, papillary, or chromophobe variety of tumors. I guess that was it. Thank you for the opportunity.